Hi, I'm Dr. Mark Student, and today with ChiroSecure, we're going to bring you bone on nerve. Is there bone on nerve in the chiropractic lesion? Whether we call it a biomechanical lesion or subluxation, and it's been bantered around and misused for decades. But the reality is that DD and BJ Palmer almost got it right. And with the technology they had back in 1895 and 1902 and 1903, when they wrote their books, The Science of Chiropractic, they were so awfully close and brilliant to even come up with those conclusions. But we're going to give you what the evidence shows. And everything I'm sharing with you is evidence based. It's all in the scientific literature. I'm not making any of this stuff up. I'm kind of just the storyteller. So let's go to the slides. So we're going to talk about bone on nerve. Now, the question is, where is bone on nerve? Where is it? And what nerves are involved? How does it work and why regional adjusting often fails? Now, we're going to unpack a lot, and I'm only going to unfortunately be able to do that today in sound bites. I can't really dig in. So we have primary spine care symposiums where we spend hours on these subjects and explain everything. And you're more than welcome to give me a jingle. I have my phone number at the back end, and I'll be able to share it with you. I'd love to talk to you about it, have a conversation. And it's not about philosophy. It's about the science. And if you follow the science, you will understand why people get well with chiropractic care. Actually, they get well too quick. That's an issue. But we'll talk about that again at a different time. So the question is, where is it? Here's your answer, folks. It's not on the nerve root. I'll tell you that right now. It is physiologically impossible for a bone to be on a nerve root. Your answer was given to us in 2017 in the European Spine Journal when we looked at Farrell and their work, and it says you've got two bones. These are called facets. And in the facet, there is a normal meniscoid that sits or seeds. I'm sorry, I'm choking here. That sits or seeds between the facets and keeps them from approximating. But when you have repetitive microtraumas, I'm going to grab a sip. When you have repetitive microtraumas or a macrotrauma, that meniscoid dislodges, and you see that on MRI clearly. The meniscoid dislodges, and that's what happens like cymbals when the bone goes up against the other bone. The nerves are the nociceptors that are on the face of the facets, and those feed in to those are your mechanoreceptors, and those feed into the lateral horn along with other things. Now, the cervical spine meniscoids, and they're in lumbar as well, referred to as synovial folds or interarticular inclusions, and they actually are the spacers. Here is your bone on nerve. Now, let's take it to the next step. Here are your facets, and this is the joint capsule, which is all ligaments, and it holds synovium in there, which has positive and negative ions, which I'm not going to get into today. But when the meniscoid goes out of place, these are your mechanoreceptors. You have your Pacinian corpuscles, they're your crimp receptors. You have your affini corpuscles, those are your stretch receptors. Then you have other nociceptors around here, and you also have Golgi tendon organs and Golgi ligament organs, which all feed into the lateral horn afferently. Now, when it goes into the lateral horn, it doesn't go up right away. What it does is it feeds into the deep paraspinal muscles through the piezo ion channels. The deep paraspinal muscles are your proprioceptors. Your mechanoreceptors tell you what's going on around you in the world. Crimp, stretch, hot, cold, thermal, okay? Muscle pulling, aberrant positioning. That's mechanically what's going on the outside. Now what's going on in your internal schema? Where is my hips with relationship to my head? Where are my shoulders in relationship to the outside world? I mean, I have a writing mechanism, which is my eyes visually. Then I have the deep paraspinal muscles. I have the ears, semicircular canal, which is your entire, the little fibrils in there, which tells you, it's like a whiskey compass, where you are. There's a lot of things for proprioception, but your deep paraspinal muscles are that as well. So now what occurs is it goes through the piezo ion channels, deep paraspinal muscles. Then it goes back to the piezo ion channels into the lateral horn. It then goes up the spinal thalamic tract through the periaqueductal gray area, and it hits the brain's clearinghouse, the thalamus. And then from the thalamus, it goes to the anterior cingulate cortex, the orbital cortex, the prefrontal cortex, the motor cortex, the sensory cortex, the hypothalamus, et cetera, et cetera, et cetera. And then it goes efferently. But does it go back to that same level? Well, we treat patients as a whole, and we have to look at spinal biomechanics. And spinal biomechanical engineering, actually, DD and BJ were incredible at studying that. But really in science, the grandfathers were Panjabi and White, orthopedic surgeons from Yale University Medical School, who came up with the whole Cartesian system of the X, Y, and Z axis of positioning where a spine should be and how that breaks down. But when we look at it chiropractically, or even in the world of spine, we know that a spine has to be plumb. Your glabella, episternal notch, and pubic symphysis have to be in a line. Top has to be over the bottom. Your ear, your shoulder, your hip from a lateral or side view have to be plumb. But what occurs if this meniscoid goes out of place and the facets don't line up, and say you're 3 degrees off, only 3, or even 2, or even 1 degree off. Well, what occurs is, if that's off, your body's going to start to tilt. If you have 2 times PIEX, 2 times ASIN, PIEX left, ASIN right. You all been through that in chiropractic school. We train in that. I taught that yesterday when I taught in the classroom in chiropractic colleges. So the point is we all know that. But we don't look crooked because the body has to right itself. So the body puts curves in there. How does it do that? Well, the body has deep paraspinal muscles as proprioceptors. So what it's going to do, it's going to fire and it's going to say, I'm off. The internal schema is going to tell the brain, I'm off. Now the brain is going to tell, if you have the meniscoid out in the lower spine, say to the left 3 degrees, it's going to tell the cervical thoracic area to spasm on the right. Then it'll tell the thoracolumbar area to spasm on the left. Then it'll tell the lower lumbar area to spasm on the right. And now you've got your nice S curve. But look, C1 is over S1. This is homeostasis. This is the lowest energy state that the body wants to bring you in. But because it's spasming here and here, your primary lesion could be here, but there could be more muscles that have to spasm up here, and there's a lot of pain. And through the gating, G-A-T-I-N-G, the gating mechanism, you're not going to feel this or this, but this. Now you have to determine, and there are pieces of technology, Simverta technology is one of them, in X-ray digitizing, that will give you biomechanical markers and tell you where the primary lesions are versus where compensation is. That's how all of this works. So if you're only adjusting regionally based upon where the pain is, you often miss the primary lesion. And even if you only adjust the primary lesion and ignore the pain areas, almost always those pain areas will go away. Because when you correct whether the primary lesion is cervical, thoracic, lumbar, when you correct it, everything unwinds, balances, comes biomechanically stable, and you don't have an issue. That is a lot to unpack. I've given you about 30 or 40 research papers of which took to accomplish all of this. I've given you a 3-hour presentation in about 11, 12 minutes, which was my goal. So if you want to learn more about this stuff, give me a jingle. Go to, take your cell phone out. You can take a picture of this QR code. These are academics. This is EMR Chiro, our software. This is Simverta, the digitizing, and our consulting platform. But take my phone number down. Give me a call anytime you want. It'll be my pleasure. So listen, thank you so much for spending a few minutes. It was fast and furious. This is my passion. I love chiropractic. There's never been a better time ever in the history of our profession to be a chiropractor. It's just so much fun. Thank you so much, ChiroSecure. Thank you so much, and I look forward to seeing you next time.